Bonjour, on va commencer. Donc, je m'appelle Janie Benoît, je suis gynécologue pédiatrique au CHU Sainte-Justine. Je vous souhaite la bienvenue à cette conférence scientifique pédiatrique qui amorce la 8e édition des rendez-vous hémato-onco-pédiatriques au CHU Sainte-Justine. Pour les participants en ligne, n'hésitez pas à écrire vos questions pendant les présentations et nous tenterons d'y répondre à la fin de chaque présentation pendant la période de questions. Donc, c'est un grand honneur pour moi de présenter mon ami et collègue de Cincinnati, Dr. Karen Burns. Dr. Burns est une oncologue pédiatrique au Cincinnati Children's Hospital. Elle est co-directrice du Cancer Survivorship Center. Elle est aussi membre fondatrice et co-directrice du Comprehensive Fertility Care and Preservation Program. Tout ça à l'hôpital de Cincinnati pour enfants. Dr. Burns a fait ses études de premier cycle à l'Université de Pennsylvanie et a obtenu son diplôme de médecine à l'Université Temple. Après avoir terminé sa résidence fellowship, elle a rejoint le Cancer and Blood Disease Institute à l'hôpital pour enfants de Cincinnati. Ses intérêts en recherche sont l'évaluation des risques d'infertilité et les options de préservation de la fertilité dans une population pédiatrique oncologique, la création, le maintien et l'amélioration de la qualité de programmes en oncofertilité et l'évaluation du potentiel de fertilité future chez les adolescents et jeunes adultes survivants d'un cancer. Donc, le titre de sa présentation aujourd'hui, c'est « Bringing Fertility Preservation to the Pediatric and AYA Oncology Population ». Cette présentation sera en anglais. Dr. Burns.
Okay. So I'm going to talk today about building a fertility preservation program in pediatric and AYA oncology and bringing this service to this population. Okay, let's try again. Much better. Sorry about that. So I have nothing to declare. I do have a long list of topics I was asked to discuss today, so let's jump right in. We'll talk a little bit about childhood, adolescent, and young adult cancer, as well as the need for fertility preservation in this population. We'll talk about how we do a risk assessment and what goes into that assessment, as well as the fertility preservation options that we have available. And then finally, our program here, the Comprehensive Fertility Care and Preservation Program. So I know many of you do oncology, so this is likely to be a bit of a review in the beginning here. But one of the things I hear most often as an oncologist is, oh, childhood cancer is just so rare. And while it's true that it does represent about less than 1% of the new cancers that we see each year, I would argue that it's really not rare. This amounts to more than 15,000 children diagnosed in the US every year, which is about 43 children every single day. So at any given point in time, we have about 40,000 children who are actively in treatment. And the average age of our diagnoses is the age of 6. So we're talking about a lifetime for these children once we are able to cure their cancer. This is a breakdown of the different things that we see. So what we see in pediatric oncology and adolescent young adult oncology is different than what we see in the adult population. So our patients are largely diagnosed with leukemia and brain tumors. This makes up about half of our overall diagnoses, with the rest made up of various sarcomas, bone tumors, and some other rare tumors. Some other things that set childhood cancer apart from adult cancers are our cancers tend to grow very, very quickly. So pediatric oncologists are not really known for being very patient when it comes to getting someone started on therapy. We tend to move very quickly from the time of their initial presentation through their diagnostic workup and staging evaluation to get therapy started as soon as possible. So from a fertility preservation standpoint, that doesn't always leave us a lot of time. Our patients do respond well to traditional cytotoxic chemotherapy. So this therapy is specific for dividing cells and cells that are growing rapidly. So it tends to work well on malignancy. It's not specific for cell type. So we see a lot of our side effects because our chemotherapy drugs also act on normal cells. We use lots of different kinds of chemotherapy and radiation therapy because they all act via different mechanisms, mostly to alter the DNA and stop those cells from dividing and hitting them at different time points in the cell cycle. In the last 10 years, it's been a very exciting time for us in pediatric oncology, with the development of more and more immunotherapy and targeted therapy making its way into the adult population and then down into the pediatric population. We have a tendency to try to minimize radiation because of the side effects that go along with radiation and that lifetime that we have to deal with after pediatric cancer. And unfortunately for us, late effects are common, so we spend a lot of time trying to minimize our late effects and trying to manage them after therapy. We try to make use of all the different modalities available to us so that we can limit our cumulative doses of any one option, again, to try to minimize those late effects. So you'll see us use combinations of chemotherapy, surgery, radiation, and our newer biologic agents. And with that, these are the 5-year survival rates that we kind of expect from most of our diagnoses. So you can see that overall, we have some variation, but overall our survival rate is at or even above 84% at this point. So our survivor population is growing, and that makes us very happy, and they're very important to us. We have probably over 500,000 childhood cancer survivors living in the United States these days, and that population just continues to grow and they continue to age. We do have some survivors who are in their 60s, 70s, 80s at this time, but the vast majority of this population are really getting into their 40s and 50s. And then younger. So as they age, we are learning a lot about the late effects and the side effects of our therapy and using that information to try to change what we do at the time of diagnosis and with their upfront therapy. And with this increased awareness comes increased awareness around the topic of gonadotoxicity and subsequent infertility, which is what we're here to talk about today. So when we talk about gonadotoxicity in this population, we're really talking about therapy-induced azoospermia, or the absence of sperm in our males, which may be temporary or it may go on to be permanent. And then for our females, we're talking about premature ovarian insufficiency or failure or early menopause. We know that this is a topic that is very important to our survivors, and you'll be hearing more about this later today in one of the other talks this afternoon. But our patients tell us that they really value information regarding gonadotoxicity and infertility, and they really value having a role in that decision-making process. And this leads to less decisional regret, even if they chose to not do anything to preserve their fertility. So having a role is very important to them. They are interested in having children. So this is true whether they already had children prior to their diagnosis, or if they have not yet started a family, but always envisioned this as something that they would want to do one day. Fertility has a large impact on their quality of life, and not surprisingly, infertility is associated with decreased self-esteem in this population. And they need information at multiple time points. So there is this information overload at the time of diagnosis, where they're just learning about their cancer, about the treatment, and about all these other things that go along with that. So not only is it important to review that information again in survivorship once things have calmed down a little bit, but for some patients, they will have further options for fertility preservation in survivorship. So it's an important topic to continue to discuss throughout the timeline. And it's not just the patients who see this as an important topic. Our experts agree as well. So our international organization of ASCO, the American Society of Clinical Oncology, as well as the Society of Reproductive Medicine, as well as our nursing societies, have all put out statements that are very similar in nature and really stress the importance of talking about fertility and the impact of treatment on future fertility. So they really stress that the possibility of infertility needs to be discussed up front when the maximum number of fertility preservation options are still on the table. You need to be aware of what is considered standard of care and research, what options are available for this population. And if you're not able to offer all of those at your own institution, you should be aware of the referrals necessary and where you can send a patient to pursue these fertility preservation options. The discussions need to start at the beginning and continue through survivorship. And we need to put our own bias aside and have these discussions regardless of age, gender, culture, socioeconomic status, or any other team bias that we may have. In order to have a productive conversation regarding infertility, it's really important to be able to assess the risk that any one patient is going to have based on their treatment plan. And it's obviously important to do this at diagnosis before therapy starts, so we have the maximum number of opportunities. It's important to readdress this with any transfer of care. I know we happen to be a large institution. We have several patients who transfer in who've already started therapy someplace else. So it's important to know what therapy they've already had and assess what their risk already is before moving forward with therapy. We need to readdress it anytime therapy changes or with any relapse and have that conversation again. Our risk exposures are additive. So every time we add something on, we have the risk that came before and this new additional risk to talk about. And then of course, to continue it through survivorship, to reassess anything that has already happened, talk about where we are now, talk about what options are still on the table and how we're going to move forward. So let's talk more about risk. Our risk variables really involve gender, age, and therapy. And pediatrics and AYA oncology is unique in that it does have to involve age because we have to talk about pre-pubertal status as well as post-pubertal status. Going back a bit to think about some embryology and anatomy, let's talk about the males first and the cells that make up the testicle and the sperm producing cells. So we have the Leydig cells, which are the cells responsible for producing the testosterone. And these are relatively resistant to therapy, to both chemotherapy and radiation therapy. So these cells will be able to tolerate higher cumulative doses without resulting in any damage or any loss in testosterone production. We also have our Sertoli cells. These are the sperm producing cells. And if you refer to the diagram on the right, you'll see that these cells are made up of really two layers. So we have the A layer, which is more of the stem cell layer, and this can create and replenish the B layer. So the B layer is the layer of cells that actually goes on to form the sperm. Chemotherapy will affect the B layer first and actually will do so quite quickly. So it does not take very high doses of chemotherapy at all to wipe out this B layer of cells and cause a temporary azoospermia. Additional doses of chemotherapy will act further and begin to diminish or wipe out the A layer of cells. As long as there are some cells left in that A layer, they will be able to replenish the B layer, and ultimately you will have only a temporary azoospermia and be able to recover some or a full sperm count. If that entire A layer is diminished or is absent at the end of therapy, then that azoospermia is going to be permanent. I just want to point out that because of the difference in sensitivity between the Leydig cells and the Sertoli cells, it is entirely possible and actually common to have males who have infertility without having any testosterone deficiency. So they'll be able to go through puberty without any problem, but not have any sperm on a sperm check. Switching to females, we remember that females are born with all of the follicles that they're going to have throughout their lifetime and begin a gradual decline shortly before birth, continuing through puberty and into menopause. The prepubertal ovary is relatively resistant to chemotherapy because it is dormant. But once puberty occurs, several follicles will mature each month, leading to the release of one or more oocytes. As the population diminishes, we begin to reach a level of a critical mass of oocytes, and beyond that, we start to see symptoms of menopause, and we would say that infertility is occurring. Chemotherapy will shift this curve to the left, as you see in the diagram on the right-hand side, and it will result in an increased destruction of the primordial follicles, leading to an earlier age at menopause. So we will define premature menopause as anything that occurs before the age of 40. So our younger patients are more resistant to this, and that curve is less likely to shift to the left, or will shift less than it will for somebody who's already gone through puberty, who is likely to have more ovarian damage. Surgery will also play into risk if it involves gonadal tissue. So removing one ovary or one testicle will result in a slightly diminished reserve. However, there's data that shows that this is not likely to be clinically relevant, and pregnancy rates do not seem to be very affected by this. Obviously, the removal of both testes and both ovaries will result in the inability to have a biological child if that tissue is not preserved. Males are at risk for secondary nerve or vascular damage with abdominal pelvic surgery, particularly retroperitoneal lymph node dissection, which is a procedure that's common in some of our solid tumor staging. So this can lead to some retrograde ejaculation and dry ejaculate. They may have normal sperm available, but this will lead to the need for artificial reproductive techniques in order to achieve pregnancy. Our radiation therapy, you might remember, will affect the tissue that it touches, so it is not systemic therapy. So patients will be at risk of infertility with radiation therapy if gonadal tissue is involved. So it works by inducing double-stranded DNA breaks in both cells that are actively dividing and in cells that are not dividing. So this will put those primordial follicles and that A layer of Sertoli cells at risk and put them at risk of depletion of gametes earlier than you would expect. So this would include pelvic irradiation, total body irradiation, as we see in our bone marrow transplant patients sometimes. It also can cause fibrosis of any of the tissues that it touches. So if the uterus is in the radiation field, you can have fibrosis of the uterus and be at risk for pregnancy complications later on. We also have to remember our cranial and craniospinal radiation because that can play into fertility as well. So with craniospinal radiation, particularly photon radiation, we can have scatter to the ovaries that may reach doses that will affect fertility. Proton radiation has less of a scatter, so this is less of an issue in patients who receive proton versus photon radiation. We also have to remember with cranial radiation that the hypothalamic pituitary axis is at risk and may lead to gonadotropin deficiency and problems with fertility down the line. It can be overcome with hormone supplementation. And then moving on to chemotherapy, we do have some newer agents with our immunotherapy and antibody therapy, our TKI therapy, which we use frequently with Philadelphia positive AML and CML, and then our CAR T-cell therapy, all of which have kind of changed the landscape of pediatric oncology in wonderful ways, in ways that are not always known yet for gonadotoxicity. So we have a lot more to learn in this area, and there will definitely be more to come. But for the most part right now, it's difficult to know exactly how to counsel patients who are receiving these newer agents. I will say we do know that TKI therapy is contraindicated in pregnancy because of the effects on the fetus. And our CAR T-cell therapy is actually, pregnancy is contraindicated in anyone who has ongoing B cell depletion because of the risks of the fetus. So there are unique categories within these newer agents that we're going to learn more about as time goes on. Our traditional chemotherapy, as I mentioned earlier, typically acts on dividing cells. And you can see a diagram here of what our alkylating agents can do. And I picked that because you'll see that that is often implicated in gonadotoxicity. So the alkylating agents in particular will cause cross-reacting and cross-linking of DNA strands that then are fatal to the cell as it aims to divide and continue to grow. The alkylating agents are important for gonadotoxicity because they are effective on resting cells. So they have the ability to affect those cells that are more quiet, so that A layer of the Sertoli cells, as well as those primordial follicles in the ovary. They also have the ability to cause cortical fibrosis and blood vessel damage in ovarian tissue, further leading to problems with fertility. There are many, many alkylating agents in use, and not all of them are created equal when it comes to gonadotoxicity. So one of the first problems that we faced in the field of oncofertility was how do you determine exactly what the risk is for someone who's receiving alkylating agents? Fortunately for us, cyclophosphamide dosing in terms of gonadotoxicity has been well established for some time now and was established before multimodality therapy was commonly used. So we were able to get good dosing parameters for cyclophosphamide in terms of gonadotoxicity. The trick was to then expand this to the other alkylating agents that we commonly use. And Dan Green and the Childhood Cancer Survivor Study were able to come up with a tool that is a mathematical equation that will allow for a conversion factor to change cumulative or total dosing of our other alkylating agents into cyclophosphamide equivalent doses. So we call this cyclophosphamide equivalent dosing, or the CED. This allows us to standardize therapy or standardize our risk categories for our patients and have a conversation about what their individual therapy is going to do for their fertility. Our initial risk categories were derived from the adult population, largely from the breast cancer literature, with categories defined as low risk, intermediate risk, or high risk. This was a great starting point. It did have a couple of problems as it pertains to pediatric and AYA oncology though. For one, that intermediate category is very large and it's hard to counsel families who have somewhere between a 20 and 80% risk of infertility. We had a hard time coming up with a way to make that better. We may have made some improvements, but also this risk category system was based on adult protocols and really did not take into account the pediatric age group, particularly not between prepubertal and pubertal dosing for our females. So those of us in the Oncofertility Consortium, which is a multidisciplinary organization that is dedicated to the research and the improvement of science in oncofertility literature, as well as the Pediatric Initiative Network, which is a subgroup of this dedicated to fertility of children and adolescents, took on this task of developing a risk stratification system that would be appropriate for the pediatric and AYA population. Some of the key articles that we used to come up with this new stratification are in the next two slides. So the first is pertaining to the males and really came from, again, from Dan Green's work in the St. Jude Lifetime Cohort Study, which is a study where St. Jude called back many of their adult survivors. And in this particular case, asked for a semen analysis from multiple male survivors and looked at over 200 patients and then risk stratified based on the therapy that they received, particularly that cyclophosphamide equivalent dosing. And what they found was that below a cumulative dose of 4 grams per meter squared, there really was no apparent effect on sperm production. Sperm counts were normal across the board. Once you got above this, however, there was really quite wide variation in terms of who had permanent azoospermia, who had a normal sperm count, and who had a decreased number or decreased motility. So we ended up switching from a 3-category system to a 2-category system for our males, saying that below 4 grams per meter squared, your risk was minimal, but above that, you were really at risk for fertility problems. A lot of our female data for this project also came out of the St. Jude Lifetime Cohort, as well as the Childhood Cancer Survivor Study. And this was able to break things down a little bit more between our prepubertal and postpubertal patients, as well as get a tighter grip on the dosing that places these patients at risk. And these are the grids that were published about a year and a half ago with our new risk stratification system. So this is the male risk, and you'll see that it is largely divided between minimal and high level and took out that intermediate category for our alkylating agents. Anybody who receives a stem cell transplant is considered to be high risk. Our heavy metals still come into play for males, and that's why that intermediate category remained, as cisplatin stays in that category because it can cause altered sperm function, but really has not been associated with permanent azoospermia. Our radiation exposures are here, as well as our surgery for the retroperitoneal lymph node dissection. And then for the females, we kept all 3 risk categories, but divided between prepubertal and pubertal dosing and aging. So you'll see those categories listed here, the same high risk category for stem cell transplant, and then radiation exposures as well. So these are our new risk meters that we can use for our patients, the female or for males receiving cisplatin on the left, and then the one on the right with the new 2 risk category. So now we have our risk categories, and we can talk about what options we have available to our patients. And I know you have more talks later today on many of these topics, so I'll kind of be a little bit brief now, and you can hear more about it this afternoon. So looking at our males first, we have our post-pubertal patients on the left in column A, and those that are prepubertal or unable to give a sperm sample on the right. So sperm preservation or sperm banking has really been the gold standard in the male population for fertility preservation. It is well established We consider it something that should be offered to all males who are able to sperm bank, to offer them the opportunity to provide a semen specimen. That needs to happen before therapy starts. So this is because the sperm are exquisitely sensitive to the effect of chemotherapy, and males will become rapidly azoospermic with even just the first doses of chemotherapy. There's also really not a defined benefit to offering sperm banking post-therapy. So remember, our males are going to become azoospermic during therapy, and then it's a question of whether they're able to recover or not. So for males who have recovered, there's really no ongoing risk beyond that. So we really want to take advantage of this pre-therapy time to offer sperm banking to anybody who might be interested. We, of course, need to balance this with the need to start treatment. But we are often able to do this for the vast majority of our male patients. There's no specific age where we start to offer this. It's really more dependent on their pubertal status. So we know that as you progress through puberty, your semen analysis is going to have a higher quality, but that doesn't mean that we don't offer it to the younger patients if they're willing and if they're able. So this usually involves a conversation with the family and with the patient and going forward from there. And typically we'll offer that for anybody who's at least a Tanner stage 3. For patients who are not able to provide a sperm sample, but do have focal areas of spermatogenesis, we are potentially able to offer testicular sperm extraction directly from these areas of the spermatogenesis. So this is something that can actually be done before therapy or after therapy. So if you have somebody who's recovered some spermatogenesis, but not enough to provide an adequate sperm sample or to achieve pregnancy, this could potentially be an option. So again, it is based on Tanner staging, with needing to be at least a Tanner 3 to have any kind of success. And this is really limited data, but still encouraging in the pediatric population. And then for our males, finally, we have the exciting option of testicular tissue cryopreservation, which has really started to come about in the last several years. So this really has been a game changer for our patients who have not yet gone through puberty, as it offers them a chance to do some fertility preservation. It's still an investigational protocol that involves the harvesting of testicular tissue, either through removing one testicle or much more commonly through a testicular biopsy, freezing that tissue, and then using it again later when the patient is ready to start a family. As I mentioned, it is investigational, so it's only done through approved IRB protocols, and really they're run out of the University of Pittsburgh. Most protocols will state that the patient has to be at high risk of permanent azoospermia based on the therapy that they are planned to receive. And for the most part, they cannot have already received high risk therapy. So this, again, is something we want to think about early on in the therapy course. We typically will try to coordinate this with other surgical procedures like a line placement or a bone marrow biopsy or something like that to minimize the anesthesia risk, and also try to minimize costs whenever possible. So there are several options for what to do with this tissue. There is the initial biopsy, and then the option to either freeze the tissue for grafting after therapy, or the option for cell suspension with them the potential to transplant that tissue back into the native environment and hope those stem cells are able to repopulate. Very exciting technology and very exciting times. It provides the potential for young males that was not there in the past. It's been successful in animal models, and you can see a picture of Grady, who is the first monkey who was born using this technique. And very exciting, the first trials have opened in humans at the University of Pittsburgh within the past year or so. So this is moving from the animal model into the human model. So there will definitely be more to come on this topic. Switching over to females, this time we have our prepubertal females on the right side in column A, or sorry, the left side on column A, and our postpubertal in column B. So for this population, oocyte and embryo cryopreservation is really considered the standard of care. So for anybody who's postpubertal, this is going to be our first line of things we think about to offer them in terms of fertility preservation. It does require stimulation of the ovary and then subsequent oocyte retrieval. We're fortunate in pediatrics that our pediatric malignancies are by and large not hormone sensitive. So doing this kind of stimulation is not a concern from an oncology standpoint. the timelines have been reduced. We used to say that we needed between 2 and 6 weeks in order to achieve this, but this has been cut down to about 10 days now. We do have to be concerned about hyperstimulation syndrome in some of our more younger patients, which is something that we can treat medically, but might cause a delay in therapy. It's going to require in vitro fertilization to achieve pregnancy after using this form of fertility preservation. We do have some pediatric concerns with this that we need to mention. One is that we have cultural concerns that we have seen certainly in Cincinnati and others as well, sometimes with the transvaginal approach to retrieving the eggs. We also have the concerns of the time frame. As we mentioned in the beginning, we typically don't like to wait very long between presentation and the start of therapy. So for the vast majority of our pediatric malignancies, 10 days is just too long to wait. So in the upfront pre-therapy timeframe, a lot of our patients are not going to be eligible for oocytes or embryo cryopreservation. However, it remains a very viable option in survivorship. So for patients who have completed therapy, still have adequate fertility and adequate gonadal function, they may be able to preserve oocytes or embryos once they have completed their therapy. In addition, oocytes has really helped us in pediatrics as well, now that is standard of care for the last decade or so. Most of our pediatric patients do not have a partner identified, so freezing embryos has not been an option for them. So oocytes has been a welcome addition. For our patients who are not able to do this, either because they don't have time up front or because they have not yet gone through puberty, we offer ovarian tissue cryopreservation. So this is an operative procedure where part or an entire ovary is removed. The cortex is then removed and grossly examined for malignant cells. It is then cut into strips and frozen for later use when the patient is ready to achieve pregnancy. Typically, when the tissue is replaced, not all of the strips are replaced at one time. The strips will typically last for several months to several years. So it's usually replaced when a patient is looking to start a family. It can be replaced in the ovarian fossa, but much more commonly placed on the contralateral ovary. So ovarian tissue cryopreservation has been around for longer than testicular tissue cryopreservation. So we have the ability to try to measure the success of OTC in our cancer survivors. So it's been a little bit difficult to get an accurate measure of success over time. Often the successes are reported, sometimes without the failures, so the denominator is hard to determine. We've used variable definitions of premature ovarian insufficiency, so at times it's been hard to determine if the pregnancy that resulted was from the transplanted tissue or the native tissue. There's been a narrow age range as well, which has limited the number of patients. And then there's always the risk of malignant cells if you transplant this tissue back into the patient. And this has been an ongoing topic of conversation in this area since this technique was developed. A few years ago, there was a meta-analysis published in the New England Journal of Medicine that was very nice and really quite nicely summarized all of the literature to date. And it was really encouraging what they found. So at the time, there were over 130 live births. And if you look at the graph on the right, you can see that around 2014, this curve really started taking off. So it's likely that this number is much higher at this point. The pregnancy rates and live birth rates were quite comparable to oocyte and embryo cryopreservation rates. And 2 patients had at least 3 pregnancies. So we know that it's possible to have patients who have that tissue last for quite some time and are able to have multiple children with just 1 round of replacing that tissue. One of the articles that was reviewed in that review series was from Tel Aviv, where they have been replacing ovarian tissue for quite some time. So they looked at their first 20 cancer survivors. Most had hematologic cancers. They were in the typical age range of 14 to 39 at the time that their tissue was cryopreserved, and half of them had been exposed to chemotherapy prior to cryopreservation. All the tissue tested negative for malignancy when they re-implanted it. They actually had 2 patients with a history of leukemia who had extensive testing who found malignant cells and were not able to proceed with tissue replacement. Another 2 had negative testing and did go on to have their tissue reimplanted. And they had very good success rates, both from an endocrine recovery rate and from a pregnancies achieved and birth rate. They also had no recurrence of malignancy in any of their patients. So from this, they concluded that there was really no difference in age at the time of ovarian cryopreservation, and no difference between patients who had been exposed to chemotherapy or not exposed to chemotherapy. They also decided or said that it was feasible in the leukemia population, but would never guarantee that transmission of disease would not happen. So based on this, they were among the first to remove the research designation for ovarian tissue cryopreservation. And the American Society of Reproductive Medicine followed suit with that in December of 2019, so almost 2 years ago now, and removing the research designation from OTC. There's still a lot of questions about this in the prepubertal ovary, though. These patients are still young, and most have not gone back to use their tissue yet. So there still remain questions about the increased time from removal to transplantation, if this tissue is going to work, given that it was never stimulated. Encouragingly, there have been 2 published reports, though, of patients who were prepubertal or peripubertal when their tissue was cryopreserved, who have had it replaced and have had successful pregnancies. And then there's ongoing research in this area to try to mature follicles in vitro, as well as take that tissue up through maturity. So with all this information, we felt it necessary to come up with some consensus guidelines regarding who should receive fertility preservation counseling, as well as the options. And in a combination collaboration with the PanCare Life Consortium, which publishes data on quality of life and risks for childhood cancer survivors, as well as the International Guideline Harmonization Group, who develops international guidelines and tries to collate ongoing research and guideline use. We developed a team of international experts in the field of oncofertility with different specialty backgrounds, do an extensive literature review and grade the evidence that was available. And as a result, we're able to formulate some tables for clinical practice guidelines for fertility preservation in this population. So this is a look at the female grids, and I know that that grid is not able to be read. I put the grid up just to show you that they took all of this information and synthesized it into a table that, when the print is larger, is actually very easy to read. So across the top, you have the exposure. Along the side, you have the different fertility preservation techniques, and then nicely color-coded, you have the recommendation under each one. So just to summarize, they did have a strong recommendation to talk with all patients, parents, and caregivers, regardless of treatment exposure, about their risk for infertility. They had a strong recommendation to talk about fertility preservation counseling with anyone receiving alkylating agents or oophorectomy, as well as a moderate for all others. For their oocyte or an embryo cryopreservation, their strong recommendation for with anyone receiving high-dose alkylating agents. Ovarian tissue cryopreservation received a moderate recommendation for anybody receiving high dose. And then ooprexy, removing the ovaries out of the radiation field, certainly if the ovaries are going to be involved. And then the question of hormone suppression therapy continues to abound. And really the team felt there was not enough evidence to really address this question with what is available in the literature now. For males, we have a similar table with a similar recommendation to inform all patients about their risk of infertility, and a strong recommendation for preservation counseling with males receiving alkylating agents or anyone who's going to be at high risk for disease recurrence. Same for sperm cryopreservation. Cryopreservation versus TESI is high dose alkylating agents. And then testicular tissue cryopreservation received a moderate recommendation for anyone receiving high-dose alkylating agents who has access to this clinical trial. This group also was able to look at the ethics behind oncofertility in this population. I did not include that in this talk today due to the sake of time, and I know that someone else, you'll be receiving more information on this later this afternoon. So taking this together, we formed the Comprehensive Fertility Care and Preservation Program at Cincinnati Children's. I just want to talk to you a little bit about what we've been able to do here with this information. So we have a multidisciplinary team that first started back in 2009 and now consists of multiple different specialties that you can see here. Within that large team, we have our leadership team, which consists of myself from oncology, as well as Dr. Sertoli Cells from our pediatric adolescent gynecology branch, and Dr. Andrew Strine from our urology branch. We have social workers and psychologists embedded in our oncology teams, and so we don't have them directly embedded in our oncofertility team, but we do use them when we talk with our oncology patients, and they're invaluable to our team. When we first started, we had everyone kind of doing everything, and that did not work nearly as well as going to the team approach that we use today. So around 2013, we switched over to our team approach, which allowed everybody to do really what they do best and really work as a team with all of our consults and bring all of our expertise to the table to do what's best for these patients and the families. As a children's hospital, we don't offer many of the fertility preservation options here on site. So we formed a close partnership with our adult colleagues in reproductive endocrinology at the University of Cincinnati, and have developed a great working relationship with them, as well as some bundle practices with our financial team here at Children's to be able to offer this for patients who might not have insurance coverage. We have streamlined the process of fertility preservation, both within our team as well as with our surgical colleagues for patients who have to go to the operating room. So we can do this as fast as possible for our patients. And we created our operational definition. So this is what we use as our operational definition. So we aim to meet with over 90% of all of the patients who set foot in CBDI, which is our Cancer and Blood Diseases Institute, regardless of their risk of gonadotoxicity from all of their planned therapy. So we want to meet with somebody whether they are receiving a lot of alkylating agent and end up in a high risk category, and the person who's not planned to receive any alkylating agent, to have that conversation with the family and with the patient about what their risk is going to be. While we want to be very inclusive, we also want to be very appropriate. And so we recognize that there are going to be some families where it's not appropriate to have a conversation about future fertility. So we developed a list of what we consider accepted exclusions from our consultation. So we'll still see these patients if the family requests, but we won't automatically have them on the list for a fertility consult. And that includes patients who had only surgery, only observation, who come for a phase 1 trial or palliative therapy only, who are a second opinion and consult only and do not stay for treatment. Anybody who comes to us who already had a fertility consult at their outside institution, unless there's been a change in their risk category. And certainly if a family declines, we will not do that. We had some initial roadblocks with developing our fertility consult team, and really worked hard with our oncologist to build that communication and trust. So it definitely helps to have an oncologist on the fertility team who understands where the oncologist is coming from, understands the timeline, can read those COG protocols to know what the therapy is going to be, and can really have that conversation before the fertility team meets with the family about where we are with the timeline, when we need to start therapy, what the therapy is going to be, and how we can best serve that family from a fertility preservation standpoint. They also had a lot of questions about who we wanted to see and what we were able to do for our families. So we spent a lot of time talking about the why, talking about our operational definition, having education sessions at all levels, from our nurses to our social workers to our fellows, our attendings, everybody along the way, stressing the ASCO guidelines and the importance of fertility preservation. Our oncology leadership, fortunately, was very behind us in doing this, and so we're extraordinarily supportive. And hospital leadership was on board as well. In our case, our US News hospital rankings involve questions about oncofertility and fertility preservation. So that won our hospital leadership over just a little bit. In terms of the question of how I'm supposed to remember to do this, we kind of went with the in-your-face approach and showed up at every meeting, showed up at all of the different team planning opportunities, thinking that if we were there, they couldn't forget about us, and it worked. We also developed multiple ways to contact us. I know Olivia Frias is going to talk more about this a little bit later today. Anytime someone said that we don't know how to reach you, it would be helpful if you had X, Y, or Z. We tried to develop X, Y, or Z. So we took that out of the equation. We really got our care managers involved. So our care managers are our navigators on the oncology side. And we have different teams that function different ways between our leukemia team and our solid tumor team and neuro-onc team and transplant. But our care managers are the mainstay through all of that. So we really got them on board to remember to add us to the checklist when there's a new patient or a relapse, so that we could get in the room and talk with the family. And our goal was to start small and to aim high and just keep going. So every time we achieved one of our goals, we would set the next and work towards that and continue that way. We also learned the importance of quality improvement science. So we are blessed with the Anderson Center at Cincinnati Children's that focuses solely on quality improvement, and our master's at quality improvement science. So in the first several years of our consult service, we had a member from the Anderson Center embedded in our team who taught us how to monitor our data, how to get our notes into our electronic medical records so we could track them, how to build our database, which went from an Excel spreadsheet into an IRB approved REDCap database, and how to make ourselves accountable. So we would report at monthly meetings for both our own team as well as our AYA team in oncology. And really every time we had a missed consult, we viewed it as a chance to get better and as a chance to improve ourselves. So we went back each time, tried to figure out what happened and tried to change the process so that we could catch them the next time around. And you can see the graph on the right, we had a little dip around 2017, and that was because our proton center opened. So without doing the QI, we would not have realized that. We would not have realized that with the proton center opening off-site, we had to develop a new way of getting those consults. And we're now moving this into our off therapy and survivorship programs. So how does our consult work? You can see that our consult is centered around our navigator. She is critical and so important to how we function and how we do things. We actually have 2 navigators at this point. So when a new patient presents, the primary team will consult us. She will get the information. They'll kick it over to the oncologist on call for oncofertility, which oftentimes is me. I have one of my colleagues who helps as well. We'll talk with the oncology team, see the timeline, get the therapy, estimate the risk, send it back to our navigator, who will then talk to gynecology for the girls, urology for our males. They'll do the consult, they'll document it in Epic in a way we can trace and in our database for our fertility team. And then from there, we'll involve anybody, surgery or research if fertility preservation is pursued. We had a great opportunity a few years ago to work with our graduate design program at the University of Cincinnati in their co-op program, which is the Live Well Collaborative, to develop some videos that we can show our families. So these have been very helpful with consults. The families are able to see them before we come into the room so they can have some idea of what fertility means in terms of cancer therapy. They're able to view them over and over again if they'd like to hear the information again. They're on YouTube. They're able to share them with family members who are not in the hospital, which has been extraordinarily helpful in our COVID times with our visitor restrictions. And they're made in a cartoon format, which is obviously not going to be appropriate for the youngest of patients, but will hopefully reach a broader audience and be able to involve the patients in the decisions whenever we can. In addition to YouTube, they're also available on all the individual MyChart applications, which is our patient-facing form of the electronic medical record. The patients can access them that way. And then our Get Well network is our internal network within the hospital, so they're able to see them there as well. In addition to the visual, we wanted to have something that families could hold onto and something that they could access easily. So we have folders that we take with our consults as well. And each folder has these cards. There's a separate card for each fertility preservation option. So we'll put the card that is appropriate for the patient into the folder. And patients are able to then compare and contrast the different options for fertility preservation. The same category is listed on each card. So they'll have this information. They can use it to take notes as well during that third piece of the consult, which is that in-person consult. We are able to ask questions and go over any options in much more detail. Our folders also contain the financial information, business cards, and other educational resources. We like to connect with families upfront, obviously at the time of diagnosis, reconnect at any change in therapy and relapse, and then reconnect in survivorship as well. So Jen Levine was able to look at the CCSS data a couple of years ago and really try to look at the female patients. And she was able to compare childhood cancer survivors and their siblings in terms of pregnancy and found that there's really no difference in the pregnancy rates in the 20s But when patients get into their 30s, there starts to be a significantly decreased number of pregnancies compared to siblings. And this really lends support to the idea that our female patients are at risk for premature menopause, and they will have a window of time after therapy where they have the option for fertility preservation before they enter premature menopause. So we have taken the option of, we start following our patients for AMH levels at about 18 months off therapy and get involved again then, and continue to follow them through survivorship. It allows us to monitor our patients for a decreasing window of fertility. It also allows us to have that conversation about alternate forms of starting a family. So start talking about adoption, start talking about surrogacy and different things like that. So these patients are growing up knowing these other options exist, knowing what their risk is, and being able to plan for it. We talk with our male patients again, offering them semen analysis if they're interested, reviewing their risk and answering any questions, talking to them about other forms of parenting as well. We still continue to monitor our data too. So these are what our numbers have looked like as they've increased over the years. About half of our patients that come into CBDI are eligible for a consult. And you can see even in 2020 with the craziness of that, we were able to switch over to telemedicine and able to continue our consults for our patients. And actually, if you look at our fertility preservation procedures, we were able to somehow do more fertility preservation procedures last year in 2020 than we did the year before. We also like to know if we're making a difference or not too. So we have looked at our patients who have pursued fertility preservation in total, as well as those who are considered high risk. And we're pretty happy to see that it feels like we are making a difference in that high risk population, with having nearly half of them opt to pursue fertility preservation. We also are able and fortunate enough to be a resource for some of these other programs who do not have all the options of fertility preservation available to them. And we have been very fortunate to be able to accommodate patients from outside of the Cincinnati area to come to do OTC and to do TTC. And this has kind of grown over the years. This also helps us on our business plan as well, because most fertility preservation programs run on purpose and are not necessarily known for their profit. So you do have to find a way to justify your existence to continue running the program. So this outside revenue is certainly helpful as we try to get comfortable with a different kind of business plan than most other divisions are able to run in the hospital. So we have used our downstream revenue impact from our outside referrals. We have used our patients to tell our proof of concept story. So they help us promote what we do. There's nothing quite like a patient telling things from their perspective to try to go to leadership and to help your cause. We are a big academic institution too. So the other way we have been able to be successful is by showing our leadership that we are academically productive and trying to advance the science in the field of oncofertility. So some of these other ways are kind of non-traditional in terms of building the team and being successful, but it has worked for us, and we all do this because we are passionate about it and we love what I do. So in closing, I just want to give a shout out to everybody who has helped us along the way, who's been part of our team. You'll probably notice somebody familiar in these pictures. Dr. Benoit was with us and we miss her. And so happy to be here today. And thank you so much for the invitation and the opportunity to talk to you guys about what we do and what we love. And with that, I'm happy to answer any questions.
Thank you so much, Karen. Hope everybody can hear me at this point. So don't hesitate to write up any questions. En fait, je vais alterner entre le français et l'anglais ici. Donc, je ne sais pas s'il y a des gens qui ont des questions. Sinon, je vais commencer avec ma première question. So, Karen, I'll start with the first question from myself. Since you've changed the risk stratification kind of card, do you counsel, like orally counsel patients differently, or does it kind of come up to be kind of the same as we were doing before, or how do you do it now?
Yeah, I think it's a little bit different now, and that we used to counsel more in that for the males, if you were in that middle category, your risk was that your sperm count could be affected, but not necessarily permanently. And then the high risk category was that risk of permanent azoospermia. And now we're really counseling that you are at risk, and that it's difficult to determine who's going to have, what the degree of risk is going to be once you're above 4. So it's changed a little bit. We've actually talked about going back and looking at the patients that we've done before to see how many patients would have been counseled differently before compared to now. I think the risk stratification system is going to continue to change as we learn more about risk in this field. And even when we created this new system, we kind of looked at it as almost a temporary system, and that this is the best that we have now. And we assume that, I don't know, however many years from now, there's going to be something better. So I think it'll continue to change.
Yeah, that makes sense. And I have another question. In terms of TTC, I know that it's not as available as OTC everywhere in the States, as well as in Canada. So have you been receiving many consults or many patients from elsewhere than Cincinnati, and any international consults as well?
Sure. So we do receive consults from patients outside of the Cincinnati area, and we do have them come here, and we'll do their TTC procedure here, and then they go back to their home institution for their therapy. All of our tissue is stored in Pittsburgh. So once we do it here, it is sent on to Pittsburgh. Our international patients are patients who've already transferred their care to Cincinnati. So they're already here for care. That may or may not have played a role in why they came to Cincinnati. But we have not had anyone come internationally solely for the TTC procedure and then go back. They've transferred care here.
Okay, thanks for the information. I don't know, I'll ask in the room. So there's few people physically in the room today, and others from virtual. I see a question, hold on. I think that it appeared in the chat. So in the chat, somebody's asking for TTC, could patients come from Canada? Anyone knows if it is covered by RAMQ or whether it is paid as research protocol? So in terms of the question to you, and then I can try to answer the rest of the question, but do you think that some people could come from Canada to go to Cincinnati for testicular tissue cryopreservation, the TTC?
I think we would be happy to explore it. I would love to say yes, and I think that I can definitely see how it might be possible. I'm afraid there might be a roadblock I'm not aware of, but we would definitely be happy to explore it if anybody is interested.
Yeah, I mean, for COVID, in terms of COVID right now, that could be some issue, but I think that the border will open soon, so that could be an idea for sure, until we have our own protocol. So as of right now, I think there's a potential that TTC could be covered by RAMQ, which is our insurance here in Quebec. Because OTC is covered by Quebec insurance, so we're very, very lucky for that. I think TTC could be covered, but it's not available. We have to work on that to get the protocol here too. And then Olivia in the chat also wrote that it's not covered by research. I think in the States, they do have organizations that sometimes help patients pay for some of the fertility preservation options, but it's not covered per se. There's a philanthropic or foundation of hospitals sometimes that do have some money for that as well. There's none here at Saint-Justin as of right now. And then in terms of it says it will be covered. So in terms of future, and I'll talk to some more in my talk, like who is covered and who is not, and I'll talk some more about that.
That's great.
So in the room, I don't know if there are any questions directly from people in the room. I don't see any hands. So thank you so much, Karen,
Thank
that great presentation. I'm so happy to see that I've been out of Cincinnati for 5 years now, and things have even like progressed even more. It's so exciting.
We miss you.
Thank you. And I hope to see you in the soon future. So thank you, everyone.
Thank you. Have a great day.